started so we can give our speaker some time to get through her slides and for questions afterwards. So it's my pleasure to introduce Dr. Lindley Barbee, who is Assistant Professor of Medicine here at the University of Washington and also has a new role. Unfortunately, is going to be leaving us, but she's going on to Atlanta to actually be the clinical lead for the Division of STD Prevention at the CDC. So this is a huge job, and so proud of Lindley for getting this job and moving on to lead the STD prevention effort nationally. Fortunately, we have her still here to speak on STDs and STD updates. So we're really fortunate to have her. So welcome, Lindley. Thanks.
Thank you, Shrisha, for having me. Today we are going to talk about maternal and congenital syphilis. And I will give some national updates, but also really focus on Washington State, as we've seen a really big rise here recently. These are my disclosures. And I also want you to be mindful that there will be some graphic images in this talk if you are in public spaces. Okay, so I'm going to do a really brief syphilis overview and then really dive into the maternal and congenital epidemiology. So syphilis is a disease caused by the bacterium Treponema pallidum, subspecies pallidum. It is transmitted through direct skin-to-skin contact. We mostly think of this happening through sex when skin touches and through kind of micro abrasions, but it also can be transmitted through blood. And what I mean by that is transplacentally through a pregnant person to the fetus. And this probably also occurs to a small degree of needle sharing, although that has not been proven or quantified. It clinically presents in 3 stages. The first, or the primary stage, presents as a chancre or an ulcer, and this occurs at the site of the direct inoculation. And I'll show some images of this in a few minutes. The body will then kind of heal this lesion and then move on to a period of secondary syphilis, which is really a systemic infection that can present in a number of ways. Most commonly is with a generalized body rash, and I'll show pictures of that as well. It then enters a period of latency. So the bacterium remains in the body, but there are no symptoms. There's probably a lower risk of transmission during this time period, but it's not zero, and it still can cause problems in the future. When it goes untreated for long periods of time, it can go into a tertiary syphilis, can also cause other neurologic issues such as blindness, deafness. But today we're really going to focus on congenital syphilis, when the bacterium has passed through the placenta to the unborn baby, because this is really one of the most devastating consequences of the sexually transmitted infections, because it can cause death and does so at a fairly high frequency. So it can cause death through miscarriage, baby dying prior to 20 weeks, stillbirth, baby dying in utero after 20 weeks, or death shortly after birth. It can also lead to premature delivery, low birth weight, and a number of other symptoms and consequences, such as bone deformities, problems with the blood cells, liver issues, and as well as neurologic issues such as meningitis, blindness, and deafness as well. What is really upsetting is that congenital syphilis is an entirely preventable disease with appropriate prenatal testing and treatment. And unfortunately, despite it being totally preventable, we have seen nearly a 3-fold increase in congenital syphilis cases in the United States over the past about 5 years, 2016 to 2020. There were over 2,148 cases in 2020 reported, and we presume that this is probably an under count given the COVID pandemic. So what we're looking at here, the blue bars represent the congenital syphilis cases, and overlying that into the line graph, we're looking at the rate, so the number of cases per 100,000 females between the ages of 100,000 females between the ages of 15 and 44. So at the same time that we're seeing the congenital syphilis, this is really in the background of an rising incidence of primary and secondary syphilis among cisgender women. So there's been a more than fourfold increase in that rate at the same time that we've been seeing the congenital syphilis rate. And this is nationally, but this is not unique to the, this is also being seen in Washington state. So here we're looking at the number of congenital syphilis cases in Washington state by year. And you can see that, you know, back in 2014, this was incredibly rare to see congenital syphilis. And then unfortunately, starting in about 2019, we started to see, you know, a pretty steep increase. And in 2021, we saw 51 cases. So an 8-fold increase in congenital syphilis cases in 5 years in Washington state. Again, paralleling the data that we saw from the United States, here we are looking at reported cases and rates for cisgender women. So this is broken down by stage. So the blue includes all stages. And then the yellow is early, which is considered primary, secondary, and early latent syphilis. And the red are late, latent, or unknown duration. So no symptoms, but positive screening test, and we don't know when it was acquired. So as you can see, total syphilis has increased significantly among cisgender women, particularly from that 2016 time point. So about a 3-fold increase. Now, nationally, you know, I think particularly those of us in the HIV field have thought of syphilis as primarily a disease among men who have sex with men. And if we look at the ratio of male to female cases, you can see, and this is a little bit complicated graph, but we're looking on the left-hand axis rate, right? The number of cases per 100,000 persons. And then on the right y-axis, we have the number of cases to one number of male cases to one case female case. And as you can see from the early 2000s, this was really a male predominant infection, right? So we peaked in around 2014 with more, you know, more than 8, about 12 to 1 cases of men compared to cis women. But then we've seen a decline, and this decline is not because there's a lowering of the male cases, but there's an increasing number of female cases. And we're seeing that locally as well. So here in Washington state, this divides the total syphilis cases in Washington state among those who are men who have sex with men, and the yellow bars are non-men who have sex with men. And we're looking at proportions here. So you can see back in 2012, more than 70% of cases were reported among men who have sex with men, and yellow would essentially be heterosexuals or men of unknown sex of sex partners. And recently, there has been a reversal or a pairing off here. So in 2020, it was about equal 50-50, and in 2021, for the entire state, we actually saw more cases among heterosexual individuals than men who have sex with men. Where in Washington state is this occurring? So the green is King County and Seattle, and about half the cases in the state do occur in Seattle, King County. But Tacoma and Spokane also see a good number of cases, as do Snohomish and Clark. But if we look at what's been going on recently in the past 4 to 5 years, there's been really a rapid increase in some of these outlying counties as well. So 250 to 400% change or percent increase in early syphilis cases, right? In Yakima, Okanagan, Benton, Franklin, Skagit, and Grays Harbor. So this is not unique to you know, the larger Puget Sound metropolitan area. This is happening all over our state. And here's just another way to look at that data by the 5 biggest counties that have heterosexual syphilis cases. We can see that a lot of this really is happening in King and Pierce, but it's not unique here, right? So all of the other counties together are having the largest increase. And so when you have a large increase among heterosexual individuals, you also are seeing more cases among pregnant individuals. So Here we're looking, the bars represent the number of cases that occurred during pregnancy, and the line graph is looking at the proportion of all cases among pregnancy-capable people that occurred during pregnancy. So as you can see, we had as high as 25% in 2016 of all cases among pregnant capable people, but that proportion has decreased because our denominator, the number of pregnancy capable people and the number of all pregnancy capable people who have syphilis has increased. And so where are these pregnant syphilis or maternal syphilis cases occurring? Again, primarily in Seattle and King County and Tacoma Pierce, but that's only 15 to 20% of all the cases in the state. They actually are happening all over the state if you look at the other green counties. Concomitantly, we're seeing the actual cases of congenital syphilis in the same high burden jurisdictions. And just to look at that another way, in 2021 of the 51 cases, most of them occurred in Pierce, King, and Yakima, but there were a few cases in all these other counties as well. So this is really happening everywhere. So what do we know about these 114 maternal syphilis cases in Washington state? If we can understand some of the characteristics, maybe we can devise better interventions. So we know that about a quarter of them occurred during primary or secondary syphilis. So these people were symptomatic, likely acquired it during pregnancy. Another quarter had early latent, so acquired in the past year, but no symptoms. So maybe acquired it during pregnancy or maybe acquired it shortly before pregnancy. And then about half were unknown duration or late latent syphilis. And that's where we feel like most syphilis would present during pregnancy because it's asymptomatic and we do screen during pregnancy. But we're starting to see more early syphilis here. It's about 50-50. Concurrent with the reproductive ages, it's occurring between individuals 15 to 44 years old. About 40% are white non-Hispanic, with 60% being persons of color. And these numbers are collapsed because the state does not report on cells with less than 10 individuals. If we look at some of our risk factors, there have been reports of exchange sex, but that really occurred in less than 10 individuals, so really in the minority. Although living homeless occurred about a third of all of these cases, so that is a predominant risk factor. 20% had a co-infection at the time of diagnosis, and over 70% had a history of an STI. And then we're also seeing about a quarter are using methamphetamines and about 10% using opiates, and that could be concurrent or separate. But I think what's really interesting is that from our partner services interviews and the risk factor, traditional risk factors that we get, which are listed here, nearly 20% didn't have any identifiable risk factor. And that makes it hard to target interventions. And that is not dissimilar to what's happening nationally. So this was a study done by some individuals at the Centers for Disease Control and Prevention. It's a little bit older data. It's from 2012 to 2016 before we saw that really rapid rise in congenital syphilis. But looking at reported risk factors, history of an STI, we saw that as well. Number of sex partners, sex while intoxicated, kind of the risk factors you might suspect. But what's really interesting is that 40% of these cases, and they had quite a few, nearly 4,000 cases, occurred without an identifiable risk factor. So what happened to these cases? So we had 114 maternal syphilis cases. And what we want to happen when we identify them, right, the preventable part of congenital syphilis is to identify the case, treat it, and avert the congenital syphilis, right? We treat the mom, and then it crosses the placenta and treats the baby as well. And This did occur in more than half of the cases. 63 of the cases were averted through appropriate testing and treatment. But as I said earlier, 51 cases or 45% were deemed congenital syphilis cases. And of those 51 cases, 35 of them had poor outcomes. So the outcomes could have meant that the baby had symptoms of congenital syphilis, was born prematurely, or was born stillborn, or died shortly after birth. And that's really a high proportion. So 30% of all the maternal cases and 70% of the congenital syphilis cases had poor outcomes. This is fairly similar to what happens nationally. So here we're looking at the number of congenital syphilis cases by year, and then divided by kind of their outcomes. How many died? That dark blue line at the top, stillbirth, the lighter blue area, light green is alive, but they had signs or symptoms, and then the dark green is alive, but no signs or symptoms. And in 2020, there were 150 stillbirths or neonatal deaths. It was about 7%. And that's been the 7% kind of death rate has been pretty steady over the past five to 10 years. So this is entirely preventable disease. Where are our missed prevention opportunities? And the CDC has put out this really nice graphic in the past couple of years, trying to identify the missed opportunities. And you can see there's actually been some changes. So this green shaded area means that the pregnant individual has not received prenatal care. And because they did not receive prenatal care, they did not have timely syphilis testing. And when I mean timely syphilis testing, I mean you have to be tested and treated more than 30 days prior to delivery. For treatment that occurs very short close to delivery, unfortunately, that even if the baby is healthy, usually we have to consider that a congenital syphilis case, and the baby still will need treatment. Okay, the second biggest group of missed prevention opportunities is the pregnant person with syphilis not getting treatment despite getting a timely syphilis diagnosis. And now maternal treatment can be very difficult. We'll talk in a couple of slides, but the only recommended therapy for syphilis during pregnancy is penicillin, injectable penicillin. And for latent or unknown duration, which we saw was about 50% of the cases, this requires 3 weekly shots. And because of the drug and the pharmacokinetics, there's not a lot of wiggle room with those days. So it really has to be every 7 days. And as we can see with some of the risk factors from these women, that they have fairly chaotic lives, and making it to 3 weekly appointments on time can be very, very difficult. And so getting that treatment done is one of the major reasons why we have congenital syphilis. There are a few other reasons here. The pink is late identification of seroconversion during pregnancy, meaning someone acquired this during pregnancy and it was identified, on the later side, not in time to treat. The orange bars are individuals who are engaged in prenatal care and their doctor didn't test them. Fortunately, in Washington State, that is a very rare event. And then the dark green here is that everything went right. The pregnant person was identified, treated, but the baby still had outcomes, clinical signs or symptoms. In Washington State, it very parallel. We're seeing about 55% are because people are not getting their prenatal care. Another 30% are diagnosed but not treated. And then, as I said, pretty rare that prenatal care but no syphilis testing. And then another small percent of those who were adequately treated, but the infant had signs or symptoms, whether this was something to do, biomedically or reinfection, it's hard to know. Okay, so what can we do about it? As I said, preventable, but you have to screen, and you have to screen your pregnant persons, but you also have to screen the larger population. And so a few weeks ago, really, Public Health Seattle King County and Washington State Department of Health released updated syphilis screening guidelines aimed at cis men and women who are heterosexual, having sex with the opposite sex. And I know this is a lot of information on one slide, and so I'm going to pull it out slide by slide. So let's start with our pregnant persons. So Washington State mandates that syphilis testing occur at the first prenatal care visit. So that should be happening for everyone. We have recommended since 2020 that we have repeat testing, universal repeat testing in the third trimester, which 24 weeks is a little early, but between 24 and 28 weeks, and really trying to time that with the glucola test, which happens around that time. So it's a single poke. And then at the time of delivery for anybody with the risk factors that we talked about, or any person who was diagnosed with bacterial STI or a first episode of genital herpes during pregnancy. And then if you recall, one of the biggest barriers was people not getting prenatal care. And this is not going to be eliminated through screening only, but because pregnant persons who are not engaging in prenatal care are at high risk of syphilis, we are recommending that anytime they present to any clinical setting, be that jail, emergency room, urgent care, substance use treatment facility, or show up on labor and delivery, that we test them for syphilis at that time. And then anyone who has a fetal demise more than 20 weeks, we would recommend testing for syphilis in that case as well. And then beyond pregnancy, we want to test the larger population, right? We have sexual networks. We need to decrease the population prevalence of syphilis. So we would test sexually active patients with any of the following risk factors at least annually, or anytime they present for care, up to every 3 months. And that would be any person who is injecting drugs, specifically methamphetamine or opiates, people who are living homeless or unstably housed, engaging in transactional sex, entering correctional facilities or have been incarcerated in the past 2 years, or if they've had a history of syphilis in the prior 2 years, they need to be tested as well. And what is more difficult to get at from the provider perspective, but is important, is that even if the individual patient that you are seeing does not report any of these risk factors, if their sex partner has any of those risk factors, we would recommend that they test for syphilis annually as well. And now the last really big new update is that we are recommending that sexually active cis men who have sex with women and cis women aged 45 and under be tested if they have not tested at least once in January 2021. And I know that this is a big new change and is a really large population. But as I said, nationally, 40% of the congenital syphilis cases were had no identifiable risk factor, and we're seeing very similar data here in Washington State. And so we need to decrease the reservoir of syphilis in the general population. And this is one way to do that: identify and treat. Okay, I'm going to move on to a little bit of the diagnosis and management of maternal and congenital syphilis. But before I can do that, as a refresher, I want to make sure that everybody is familiar with some of the signs and symptoms of primary and secondary syphilis. So this is where I'd say, if you're in a congregate setting or with people around you, please be mindful. There's going to be some graphic images. Okay, I wanted to make sure everybody had seen multiple images of primary syphilis so that they could recognize it if they saw it. This is a classic chancre on a penis. It is a well-demarcated ulcer, kind of looks punched out. If you felt the edges, those would be firm and kind of indurated. And the patient might not think that they probably noticed this one, but might not have, because it's not usually painful. Here's one though on the side of the mouth. This may look kind of like a herpes or a canker sore, but that is also a primary syphilis lesion. Often these lesions go missed because they are an interior orifice. Here is a perivulvar, another vulvar, another mouth lesion. This certainly looks like it could just be a canker sore. And then here is a lesion on the middle of the tongue. This one I think looks a little different. That white stuff I think is the flash from a reflection of the flash. And then images of secondary syphilis. The classic rash is this kind of light pink, slightly maculopapular rash all over with some lesions on the palms or soles. Lesions can be different, either hyperpigmented or scaly. And this is one that I really want people to recognize. This is condyloma lata, which looks like kind of wet warts, wet and shiny warts. And unfortunately, we've been seeing a lot more condyloma lata. This is anecdotal, but over in the sexual health clinic, we've been seeing a lot of condyloma lata, particularly among cis women. And unfortunately, it's getting missed as warts or herpes. And so I really wanted people to see this image. Here's a variation of the rash where it seems a little bit more discrete and punctate. And then here are some lesions on the sole that look almost like blisters. And then this one looks almost like psoriasis, but is a secondary syphilis rash as well. This may be considered Lewy maligna in someone with advanced HIV. Secondary syphilis can be very, very confusing. There is a reason that syphilis was called the great imitator. It can present in many different ways. I have seen secondary syphilis be as subtle as a few what looked like to be bug bites, literally 5 bug bites. And it was a rip-roaring secondary syphilis with a 1 to 256. I have also seen people who were admitted to the burn unit at Harborview because they had a ulcerative desquamating rash all over, and there was concern for Stevens-Johnson. Secondary syphilis can be confusing. Keep your eye out and keep it in the back of your mind. So how do we diagnose? I would really like to emphasize here that primary and secondary syphilis are both clinical diagnoses. You do not need to wait for your serologies to come back to make the diagnosis or to treat. In fact, I would urge you to treat based on anything that looks like a primary lesion in a sexually active individual, and same with secondary. Wet lesions, so the chancre or those condyloma lata that are kind of wet, have treponemes in those lesions, and so you could diagnose them through dark field microscopy. So taking some of the liquid, putting it on a slide and looking at it under a special microscope called a dark field microscope, and that's what we're seeing here. You can see the treponemes are spirochetes, I mean they're like little coils, and they're running around, not running around, but kind of like flipping around. It's very cool to see. Unfortunately, there's really only 2 dark field microscopes. They're both here at Harborview. One is in the sexual health clinic, and if you're working at Madison, we'd be happy to help you look under the microscope. And there's another one in a lab also here at Harborview. And then you have your serologies. As I said, serologies really should not be used for primary syphilis. I would treat and send them on the same day to get a baseline, but I would not use them to diagnose. In particular, because your test can be falsely negative. Just like with HIV, there can be a window period from the time of acquisition until the time the antibodies become positive. Secondary syphilis, you can also get your serologies, either non-treponemal like your RPR or your treponemal test, but again, that should not deter you from treatment. And then latent syphilis, by definition, as an asymptomatic infection, is a screened infection, and you need to use your serologies for this. And we're not going to discuss neuro today. So Barbee primarily works with the reverse sequence syphilis screening algorithm. And that is to use a treponema specific test, an EIA. First, if it is negative, you can say that this is no disease, except if you suspect a primary or very early syphilis, and it could be in the incubating stage. If it is positive, then you need to go on and look at your non-treponemal test, a quantitative non-treponemal test for an RPR. And if that is positive, this is likely to be new disease. If this isn't a person who's never had syphilis in the past, I would say this is a new syphilis and it needs to be treated. But if it's someone who's had syphilis in the past, then you need a little bit more information and you need to talk to your patient and look in the medical record for their last RPR and determine whether there has been an increase in their RPR. If you have a positive EIA and a negative RPR, then you do a third test, another treponemal specific test, and that's kind of a tiebreaker. So either it is negative and you think that maybe your first test was a false positive, or the rare case that you have two false negative tests, which I don't think is really going to happen very often. Except in maybe very early disease. If it is positive, then you say, well, maybe this is very early disease, or maybe it's somebody who's been treated in their past and the RPR has waned. I say all this, it is not straightforward. Syphilis is complicated. You cannot rely only on your serologic testing. You also need to talk to the patient and know the history, and also look for past syphilis testing, and we can help you in public health if you think they've been in other healthcare systems. Okay, syphilis treatment in pregnancy. Penicillin is the only effective drug to treat syphilis in pregnancy, and so patients who report true penicillin allergies require desensitization. I capitalize true because people, over 10% of the population reports that they have a penicillin allergy, and the truth is less than 1% of individuals truly have a penicillin allergy. So I think the first step when someone says they have a penicillin allergy is to really dig deep and say, when was it? What was it? How did it occur? When did it occur in relation to taking the medication? Which medication was it? If it occurred, my mom told me when I was a baby, I would ignore that and say, you are going to be fine. It is more important to get you treated, and we will watch you for 15 minutes or 30 minutes, because this is really important to get these individuals treated. And I've seen a couple of cases of congenital syphilis that occurred because people were concerned about a reported penicillin allergy and referred to allergy, and patients could not make it there, and unfortunately didn't get treated in time. So for primary, secondary, and early latent, it's a single dose of benzathine penicillin. For late latent or unknown duration, it's 3 weekly shots of benzathine penicillin. We talked about that already. Because of the pharmacokinetics of benzathine and the increased volume of distribution during pregnancy, there really is very little wiggle room in the dosing schedule, right? So we really want individuals to get dosed every 7 days, maybe up to 9 days, but really beyond 9 days, you have to start the series over again. And as I said, even getting 1 shot in can be difficult, so getting 3 can be very, very difficult. One thing to know about this can occur in anyone, but in pregnancy, we may need to think about it a little bit more, is the Jarisch-Herxheimer reaction. So this is a flu-like illness or a febrile reaction after the injection of penicillin. Basically, the bacteria are lysing and releasing endotoxins and lipoproteins, causing this cytokine storm, and they get fever, malaise, nausea, vomiting, chills, exacerbation of their rash. It occurs often in secondary when there's just so many treponemes in the body. It is self-limited. It occurs within 24 hours and resolves within 24 hours as well. You can offer some anti-inflammatories. But what you need to know for pregnancy is that this can precipitate labor. It doesn't always, and it doesn't mean you need to admit the patient for observation after their treatment. It just means you need to counsel your patient and say, hey, if you start to feel like you're having some cramping or labor, please come back. There are a few other special management considerations during pregnancy. There is some limited pharmacokinetic data that suggests that even in early pregnancy, you might want, or early syphilis, you might want to do a second dose of bicillin after 7 days. And that is really based on the volume of distribution during pregnancy. May not be as important kind of earlier on in pregnancy. If diagnosed after 20 weeks, it would be recommended to get an extra fetal ultrasound to check for congenital syphilis kind of in utero. We talked about this, that it can really precipitate, Jarisch-Herxheimer reaction may precipitate premature labor. I'm probably preaching to the choir here, but pregnant persons who are diagnosed with syphilis should also be tested for HIV, as well as other STIs, gonorrhea, chlamydia, trich, and the hepatitis. So the ongoing management, let's say we have a patient, they're pregnant, we've diagnosed them with syphilis, they get their treatment, which is wonderful, but we want to follow their titers over time and see those titers decreasing. The CDC guidelines say at least 8 weeks after treatment, and again at delivery. I'm a little bit more conservative with any syphilis in pregnancy, and I would recommend every 4 weeks until delivery. Really important to make sure that all of the sex partners get either a single dose of benzathine penicillin as empiric treatment or doxycycline for 14 days if they report a penicillin allergy. It is really important that you don't just test the sex partners and wait for a positive result, because you can encounter incubating syphilis, particularly if the exposure was recent, and that then allows for reinfection in the primary patient. And in pregnancy, we really want to avoid reinfection. Okay, so a little bit, a few images of early congenital syphilis. I am not a pediatrician or a neonatologist by any means, and so I have actually not physically seen the babies. I have talked to a lot of providers who have seen these babies over the past couple years, but some of the common signs or symptoms include osteochondritis and periosteitis. We get long bone x-rays to look at these deformities. This baby has some mucus patches on the roof of his mouth. This baby has snuffles, which is nasal discharge. You can see here. This nasal discharge can be tested either under a dark field microscope or using a PCR for treponemes, which would be diagnostic. And then rash is very common as well. So this baby has kind of a desquamating rash. I alluded to earlier that there's really kind of two case definitions of congenital syphilis. One is the infant criteria, and anyone with those signs or symptoms that I just showed you on the images of the babies would meet infant criteria, or having an RPR titer that is more than 4-fold higher than mother's titer, or having a positive dark field microscopy or PCR of any skin lesions or that bodily fluid would be proven or highly probable congenital syphilis. But there's also a maternal criteria. So baby could look good now at delivery, but mom had syphilis and was not treated or didn't receive adequate treatment, either not all of the injections or kind of not on time, or treatment was completed less than 4 weeks before delivery. And that would meet a case definition of probable congenital syphilis. And depending on where the infant falls in these two case definitions depends on the workup. And this is a lot of information as well. I'm going to go through it slowly. But I wanted to give this reference. This is available from California. California has seen the most cases of congenital syphilis in the past 5 to 10 years and have a lot of really great resources. So if you are interested in resources for this, please visit California Department of Public Health. So if we start at infant criteria, so we have signs or symptoms on physical exam, or baby has a high titer or positive dark field or PCR of any of the lesions, then the baby needs a more thorough workup, including a lumbar puncture for VDRL, cell count, and protein, because these babies can have meningitis or neurosyphilis. They need a CBC with diff, long bone radiographs, and other tests as clinically indicated. And then if any of those are abnormal, and probably even regardless of that, we're going to go ahead and treat the baby with 10 days of IV crystalline penicillin, and the dosing is there. But let's say the baby looks good, doesn't have any of these findings, but meets maternal criteria because mom was not adequately treated. This is kind of possible congenital syphilis. We still do the workup, and then if any abnormalities, gets the 10 days of penicillin. But if no abnormalities and baby's going to come back for all its prenatal appointments, then you do sort of like epi treatment or empiric treatment that we did for the sex partner. We give a single dose of benzathine penicillin, and that's really to kind of get at the possibility of incubating syphilis, because congenital syphilis can present at any time, right? Baby can be fine today and present at 2 months with symptoms, or 6 months, or several years later. So let's say mom was treated appropriately, has not been reinfected. This is very less likely congenital syphilis. You probably don't need to do a full evaluation. Look at mom's titer, make sure that those titers have been going down. If there's any concern that maybe the titer hasn't gone down fourfold, then give the baby an epi treatment shot. Otherwise, just follow the baby closely with doing serologies for the baby every couple months for the first 6 months. So this is just kind of my a quick summary slide that we have seen a more than 8-fold increase in congenital syphilis in the past 5 years in Washington state. This is not unique to Washington state. It's happening all over the country. And it's really devastating, because this is definitely a failure of public health to be able to screen and treat individuals prior to this happening. So in summary, syphilis is rising among cis heterosexuals, cis women, and pregnant persons, and congenital syphilis is at an all-time high. It's totally preventable with timely testing and treatment. So test all pregnant persons at the 1st and 3rd trimester prenatal visits, or those who are not engaging in prenatal care anytime they present to care. Screen cis heterosexuals at elevated risk of syphilis frequently, and ensure that all sexually active persons under 45 years of age have been screened at least once since January 2021. And my final caveat, as I really focused on the heterosexuals here, we have not changed anything on our MSM screening guidelines. Continue to screen MSM at high risk every 3 to 6 months, and at low risk once per year. A few other resources. Most of you probably are aware of David Spock's National STD Curriculum. It's really a beautiful website, and you can earn CME and CNE using that. And then I really think if you want to do a deeper dive into diagnosis and management of syphilis, this is a great monograph produced by the New York City Department of Health and Mental Hygiene, as well as the New York City STD Prevention Training Center. And it's really thorough and well done. And that is what I have for you. If I see if there are some questions and some chats, which I think we have some time to answer those. But if your question does not get answered, please feel free to email me at my email there. Thank you so much.
Thank you so much, Lindley. I will go through some of the questions here because I think there's a few of them in the chat and also in the Q&A. Let me start with the Q&A. Does a pregnant woman, female, need to complete a 3-dose regimen of syphilis treatment 30 days prior to delivery if it's latent or latent unknown duration, or does the regimen need to just be started prior to 30 days before delivery?
That is a really great question. I say they need to complete it. So they need to get their 3rd shot more than 30 days before delivery. But I don't, that is my interpretation.
Thanks. I'm trying to think. I actually had a question about point of care syphilis testing.
Yes.
Some of the populations that you mentioned are a bit harder to reach that we're trying to outreach to, in particular persons living homeless, and getting them to come back for treatment if their testing is positive in the ED or in outreach clinics. Is there a recommendation for using these point of care testing? Is there point of care testing that is that could distinguish between prior infection and kind of just a regular antibody type of testing, like you mentioned?
Really good question, Sharisha. So a couple of questions in there. So point of care testing, not CDC recommended, but public health does recommend using this. And we've been working with different places to implement it. So we've been implementing it at SCORE and some of the jails, and Harborview is working on validating to be able to use it in the ER, particularly for pregnant persons. And then I'm hoping that you all are doing it at She Clinic as well. They're not perfect tests and they are antibody only. So it can't distinguish from old infection. But for someone who doesn't know that they've ever had a history of syphilis, it can be really great because you can use it, test positive, and treat them while getting the confirmatory labs that take some time to come back. And then, hopefully confirm the infection. And if you don't confirm the infection, if it was a false positive, which occurs, they're not perfect tests, their specificity is, low 90s. Penicillin is a pretty low risk intervention in someone who doesn't have a true syphilis allergy. There's no really good test still to determine between old or new infection outside a point of care test either, right? So if someone has had syphilis once or twice or multiple times, the only thing we really have is the RPR changing titer, and that can get really confusing. So we definitely need better syphilis diagnostics.
Thank you. And we are using it. We just started using the point of care testing again at She, so we'll let you know how it's going. But we are seeing a number of women with syphilis.
Yeah.
Someone is asking, what is the timeline for getting confirmatory results, presumably after an antibody test is positive? What is the timeline for getting the confirmatory?
Hi, Katie. So it totally depends on which healthcare system you're working in. We've been working with Harborview to really speed up getting those RPRs back. But for a while there, it was taking about 2 weeks to get RPRs back. So it can take a while. Do you want me to? I'm seeing some of these. Daniel Burke is asking, how about low or no prenatal care as a risk factor? Certainly a risk factor, and that's certainly definitely one of the risk factors. We did not capture that in that data. Let's see. Jarisch-Herxheimer reaction only with the first dose. Leslie's asking, yes. So usually it happens during the Jarisch-Herxheimer reaction usually happens during secondary, which is only a single dose, but could certainly happen for somebody after their first dose, not with the second and third. I think this will be, someone's asking about a copy of slides, and I think this will be available recorded on the website. And Elaine Thomas is asking about a Dear Provider letter. Yes, if you didn't get it, that we sent out, Public Health, Seattle King County and DOH sent out a Dear Provider letter in the kind of middle end of May. And thank you, Victor, for putting the link in the chat box. Okay. Shrisha, anything else?
No, it doesn't look like there are any other, oh, well, let's see. Is Seattle King County Public Health engaging syringe service programs and other community-based drug user health services about this topic?
Yes, we are working with our local SSP and trying to roll out rapid testing there. So, you know, operationalizing for a test and treat strategy is a little harder in the SSPs. But yes, we are working with a number of groups and on a number of different interventions to help combat this problem.
Thank you so much. These were great questions too. And thank you so much, Lindley, for this really amazing presentation and really important topic, as we're seeing lots of STIs, including syphilis, despite the pandemic. So it's really important that we don't forget about these other things that are going on.
Yeah, thank you for having me, and thank you all for attending and being interested in learning more about syphilis and what's going on in the community.
And lots of congratulations in the chat box for you.
Okay, thanks. I don't know where the chat box went, but thank you, everyone.